Well, hello, everybody.
Hello.
Hi, Dr.
Hello.
Brooks.
Okay, so looks like we have Andy. Looks like we got Dick Stewart, Jennifer. Kay Israel is with us. Hi, Kay.
Hi.
Roy Adams. Roy, are you with us?
I am.
Excellent. Jennifer, can you hear me?
Yes, can you hear me?
I can.
Yes.
And Dick, can you hear
Yes,
me?
I
Excellent. Excellent. And then Andy, just want to make sure you can hear me. Andy, you there?
Can you hear me?
Barely. I can barely hear you, but I can hear you. Let's give folks a couple more minutes to join us, and then we'll go ahead and get started.
Sounds good.
In that meantime, does anybody have any questions or anything that I could answer for you? Any interesting cases today?
I had some CRDs today.
Excellent. Excellent. So what are CRDs indicative of?
Isn't it just the muscle deteriorating, essentially, dying?
That is one cause. Uh-huh. Yep. What is the other cause of CRDs? They can be seen in chronic myopathy, and they can be seen in chronic axon loss lesions. So the key word there is chronic.
Mm-hmm.
Mm-hmm.
Is it normal to find them in just one muscle?
Yeah, that is not unusual at all. You'll sometimes in patients that maybe have a little bit of a chronic cervical radic, you might find them in cervical paraspinals at one level. In patients that have chronic severe axon loss, carpal tunnel, you're going to see them in the APB. Usually when you see them in multiple muscles is when you have more of a systemic type of condition, like a myopathy or something like that.
Mark, your sound keeps cutting out on my end.
Oh, it does?
Hmm.
Guys, is my sound cutting out for everybody or?
No, fine.
It's through fine for me.
Okay.
Hey, while I have everyone, I just switched over to Summit about 3 weeks ago. Do you ever see any problems with yours where the system stops or the program stops?
Yeah, Roy, this is Mark Brooks talking. Yeah, we even in class, we see that happen all the time. You'll be in the middle of a test and the system will just lock up.
Yeah.
And, basically, you have to just shut everything down and, start it up again. Have you talked with Cadwell about that yet?
Yeah, they made some changes in the system and it didn't do a thing.
Okay.
I was today, I had 2 tests and I probably had 4 stops between the 2 tests.
Okay. Yeah, that is not good. Did you buy your system new from them or?
No, I didn't buy it. I bought it. Trying to think. Craig out in.
Okay.
Yeah, I bought his.
Yeah, Roy, what you may end up doing is you may end up packing it up and sending it out to Cadwell and just have them go over it real quick.
Yeah. Well, they already did that because what we did was Craig, that was part of the deal, was they recertified it. So I have a warranty on it. But like I said, it was just one little annoyance. It's a small thing compared to what I was having problem with the Wave.
Uh-huh.
But
that's funny because in our practice, I've got 8 Tekka Synergy systems, which are the ones that I use, and I pretty much keep a system at each office, that I go to. But we've got 2 Wave systems, and we've got 1 Summit system, and we just don't use the Summit, at all. I mean, I bought new laptops, Windows 10 laptops for those Wave systems, and it is rock solid. I mean, that's a rock solid system. The Summit is still so new that I think they're working out, some of the kinks with it. So,
well, I still have the Wave system, and part of the issue was just it was pretty worn.
Yeah.
Got it. And I'm kind of figuring I'm going to use that as a backup and probably update it here.
That actually sort of sounds like a plan there. Okay, so can everybody see my screen?
Yes.
Okay. So those of you that were with me last week, I had mentioned about doing, something about, CMAPs and, what does a low CMAP means, but, it's, over the past couple of weeks, or so, talking with Dr. McKibben, talking with John Lugo, we sort of get together and talk, and, we talk about how damn hard it is to be a mentor. It's freaking tough, okay? Because on one hand, you sort of build a relationship, with the person that you're mentoring, and then on the other hand, you have to give them bad news about things like, their exams and stuff like that. So what I thought I would do for tonight's on a webinar is I'm going to put you guys into the position of being a mentor and having to review some reports and maybe see what we sort of deal with. Okay, just from the report review standpoint. One of the things that I try to teach the people that I mentor is to question everything, question every bit of data, that you acquire. Because if something just doesn't seem right, it's probably not. So for this evening, what I'm going to do is I'm going to present 3 cases, 3 reports that have all been done here in the last probably 5 or 6 days, or so. And I'm going to present them in the way that I look at them when I get a report. Okay, so one of the first things that I look at is I look at the data table, and let me go ahead and get this started. Otherwise, I'll keep talking and I'll forget to do this here. And before you know, it'll be 9 o'clock, and we're done. But what I want to do is sort of go over how I look at a report. Okay, what I look at first, and then I want to sort of convey how I interpret data. Okay, is there something that just doesn't make sense? And I think I've seen, over the past 23 or 24 years, I think I've seen about everything. But maybe I haven't. Okay, so I'm gonna present 3 cases. One of them is going to be a focal entrapment. The other one is going to be on radiculopathy, and the third one is going to be a systemic on a condition. And those are the 3 categories of reports that you're going to have to submit. When it comes time to take your your board certification. And I want us, i.e., mainly you, just to look at the data and question it. And then once we look at the data, we can look at the waveforms and we can look at some stuff. And then I want to put you guys in the position of giving some feedback. Pretend like I'm the student. I'm the one that just submitted this on report, and I want you to give me some feedback here. So our first case is going to be a focal entrapment case. This is a patient, and really all I need to say, this patient's having hand numbness. So take a look at this data. Somebody give me a quick summary of the sensory nerve data. This is not everything. I only put in the pertinent stuff here. So somebody give me a summary of what's happening with the sensory component of this test.
Median sensory nerves are exhibiting prolonged latencies and slowed NCVs.
And even in Florida, you can read. And Jennifer will readily recognize this is probably somebody that I'm mentoring because I and Dr. McKibben, we actually make you write something out. We don't allow you to use the machine generated component. So both median sensory nerves are exhibiting some prolonged latencies and some slowed NCVs, and this certainly fits with a patient that has some median nerve entrapment at the wrist. Okay, somebody else take a look at this median motor data and summarize that for me. Anybody? If somebody doesn't volunteer, I'll call on somebody.
Well,
Looks like there's slowed conduction velocity in both the left and right median motor nerve
Yeah.
at the APB.
Yeah, and what segment is that slowing in? Is it the same segment that's being assessed when we do the sensory part of the test?
no.
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 Do we normally see in patients that have carpal tunnel or have median nerve entrapment at the wrist, do we normally see a blazing fast latency and a slow forearm
No.
NCV? Okay. So we're going to question this. Okay.
Right.
When I saw this, I'm going, I don't know about this. Somebody else look at those median motor amplitudes and tell me what's going on here. This data right here.
Yeah. Well, we have elevated amplitude, don't we?
Okay. What's going on here?
It is dropping at the proximal stem site.
Yeah, amplitude is dropping at the elbow.
Yeah.
And, how much are we allowed to drop between segments and still call that okay for a motor?
Was it 20%?
Yeah. 20%.
Mm-hmm.
Absolutely.
Yeah.
So this is more than 20%. Okay. So when I see this in combination with the slow nerve conduction velocities, I start to question
Yeah.
what I'm seeing here in this tabular format. So what's the next thing I'm going to do after I've looked at the data table? What is the next thing I'm going to look at?
Look at the waveforms. And stuff.
Yeah. Absolutely. Here's our waveforms.
Interesting.
Yeah. So somebody tell me what's happening here. Somebody describe these two waveforms.
Well, you got deflection before you're starting on.
Kay is raising her hand. Kay, I'm sorry, Kay. I thought I had allowed you to talk. Okay, so you should be able to talk freely.
Okay, there we go. Can you hear me?
I can.
This looks like conduction, volume conduction.
It is. Volume conduction of what?
The ulnar nerve
Yeah.
at the elbow.
Yeah. Well, no, not at the elbow.
Oh, it's not?
No.
The wrist.
It's at the
At
wrist.
the wrist.
Yeah.
Okay.
Because we've got this.
Well, how do you know?
Yeah, how do you know that?
Because we have a positive deflection.
Yeah.
Here, we do not have a positive deflection at the elbow,
Yeah.
but we have this positive deflection at the wrist. Plus, we have a much larger amplitude.
Right.
Okay, if you look at this side over here, if you look at the right side, the waveform actually looks smaller than the left. But look what they did with their gain. They changed their gain to 10,000.
Oh, I see that.
Yeah, so it's actually twice as high. Okay, so the waveforms that are being recorded at the elbow are perfect. The issue here is at the wrist. Okay, and when that onset cursor gets pushed more to the left, I mean, that cursor is in the right position. It's just that the waveform is wrong. When that cursor gets pushed more to the left, then there's a longer latency between wrist and elbow, and that is what's giving us our slow nerve conduction velocity.
Right.
Here, okay? So let me get to the next page here. Okay, so we've talked about some of this. Identify the data that's questionable. Well, the data that's questionable is that slow forearm NCV in a patient that we think has median neuropathy at the wrist. Okay, so that so we're questioning that. I never see this. I never see a slow forearm NCV unless I have a very, very low amplitude CMAP. Okay, and when you have a very low amplitude CMAP, what that means is that your largest, fastest firing axons have been killed off or are being blocked. And then you can see some slowing, but that's almost always seen with a very prolonged latency. This latency is blazing fast here. Now, if we move that cursor from here to here, then we're going to have a latency probably around 4.6 or 4.7. Okay, which is going to be abnormal. Okay, so the second question here: why are the CMAP amps smaller at the elbow versus the wrist? And we've answered that. We're getting volume conduction of the ulnar nerve. Okay, describe the causes of that slow forearm NCV. The cause is the onset cursor at the wrist is moved more to the left, which gives you a longer latency. Okay, that's going to give you an artificially slow nerve conduction velocity.
Basically, they're just not on the nerve.
That's going to be one of the questions here in just a second. Okay, so describe the morphologies. look how the waveform actually looks a little bit different.
Yes.
Okay, you see how this is sort of round and smooth. This is sharper. Okay, we've got a positive deflection. Okay, so what's causing that morphology change is volume conduction of the ulnar. Okay, what is the significance of that positive deflection? Volume conduction of the ulnar nerve. Okay, so what two things could be happening that is getting us this volume conducted response at the wrist? One or two or both?
Pulse width is too high.
Yeah, stim intensity is too high. Okay, you could certainly be on the median nerve, but if you're shocking too damn hard, okay, and you're starting to stimulate the ulnar nerve, you're going to depolarize that nerve also. What is the other thing that can cause this?
Pulse width?
Well, no, that all gets back to, intensity versus pulse width.
Okay.
What is the other thing that can bring in the ulnar nerve and still
If you're stimming too close to the ulnar nerve.
Yeah. This patient could have median ulnar nerves that run side by side there, or not paying attention, you've let your stimulator just sort of slide on that gel a little bit more medial than what it should be. But either freaking way, should this have made it to me?
No.
No.
This should have been caught at the time the test was done and the patient was lying on that table and fixed.
Correct.
At that time. Because now what's going to happen, this patient's going to have to come back and this test is going to have to be redone. Okay? So what can be done to correct this volume conduction? One, if, verify that you're actually on that median nerve, and, chances are, this person was, okay? But turn down that intensity until you see that waveform change into the same configuration as we have at the elbow. These waveforms should not ever change shape significantly from one stem site to another. Should not, okay? Let's go back to the first page here. Let's take a look at our impression, okay? So based upon this data, and it looks like we may have a couple of more people have joined us here. Kelly from Alaska has joined us. And then Shelly from Kansas has joined us, and they should be able to participate now. Based upon this nerve conduction summary, okay, bilateral median sensory nerves exhibited long latency NCVs, and bilateral median motor nerves exhibited slowed forearm NCV. Is this the correct impression based upon that data? No, it's not, because that forearm NCV being slow ruins this. Ruins this thing about the wrist. Is it possible that the compression could be slightly proximal to your stem site at the wrist? Yeah. But that's why we look at the waveforms. And when we see these waveforms, to me, it's readily apparent what's happening. And for you guys, it should be also, because I beat you about the head and shoulders about this, okay? These waveforms should look the same. They shouldn't change shape, okay? And we need to identify this and be able to fix this at the time that we see this. Okay? So let's take a look at the sensories. These are the sensory waveforms from the same study. Any comments on these sensories?
They don't match either.
They don't match.
Yeah, there's a little bit of an amplitude difference. Now, with sensories, you could see a little bit of change in shape because these things are so small, okay? We're dealing 20 microvolts per division for a sensory, and on this motor right here, we're doing 10,000 microvolts. So these sensory responses are 1/500th the amplitude of a motor. So you can see a little bit more, variability. This is usable data here. We've got a big stem artifact, over here. How can we rectify a stem artifact?
Turn it down. Less intensity.
Yeah. Turn down the intensity a little bit, or we can, rotate that anode, around. What I'm also noticing is that for the amplitudes, we're using peak to trough.
Mm-hmm.
Okay. And that's okay as long as your norms are, set up for that. But also be careful, especially when you do the ulnar nerve, about getting motor artifact. Because if you have some motor artifact, that can pull this trough way down. And then all of a sudden, you've got 150 microvolt on a response, and the other side is 50, okay, which is still large for an ulnar, and you're calling an ulnar sensory neuropathy there, okay? So just be careful. With that, but this certainly is, very usable data. Okay, so what can be done to correct these issues? Can your mentor move any cursors around that is going to make this data correct?
No.
No. Okay, I can maybe move that cursor there, which will get me a more accurate onset latency, but I'm still dealing with two different size, amplitude, responses. And we can't let that go. So in this case, unfortunately, what will need to be done is this patient needs to come back, okay? And the median motor tests need to be unrepeated, okay? But the big take-home message here, guys, is we got to catch this stuff at the time that we do it, okay? I harp and I harp and I harp and I harp about reviewing your data as you generate each wave. Hello? Who was that? Okay, but review your data as you collect it. Give your mentor a break, okay? Because again, what I truly don't enjoy doing is saying, yeah, everything looks good here except for those median motors, and there's nothing I can do to fix them. So bring that patient back and do it again. That really sort of sucks, for me to have to tell somebody to do that. But in this case, there's really nothing I can do to fix this here. Okay. So take home message, review that data as you collect it. With these motors, make sure that your amplitudes are consistent, make sure that the morphologies don't change. And if you see something in a patient, everything in this patient's clinical exam was pointing to carpal tunnel, and you see slow forearm NCVs, question that data, okay? So any questions about this? This is pretty straightforward. This is fairly easy. This is stuff that we've talked about before in webinars. Now let's take a look at a couple of real gems here. Okay. Polyneuropathy. Okay, so this is what I got. Okay, looking at this is the machine-generated report. Okay, to me, this is impossible to read. here. Okay. And then I went down to, to the EMG summary. Pretty much every muscle was abnormal that was tested. And then I looked at that impression. Okay. There is electrophysiologic evidence suggestive of chronic axonal pathology affecting lumbar L5-S1 nerve roots on the left and chronic axonal pathology affecting lumbar L5 nerve root levels on the right. Okay. There is insufficient electrophysiologic evidence suggestive of a peripheral nerve, entrapment. So when I see the machine generated report, first thing I do is I look at the tabular data here. Okay. So somebody take a look at this tabular data and tell me if this data is consistent with chronic axonal pathology affecting the L5 and or S1 nerve roots.
No.
Okay, and why not?
Well, I'm trying to see what our abnormalities and our amplitudes for one.
Yeah. Well, look at the red boxes of death.
Oh, yeah.
Okay. So, question one, identify data that is abnormal.
Yeah.
Okay, so we have no sensory responses.
Yeah.
But the patient or the tester notes that there's moderate edema in the lower leg and ankle, which is not uncommon. Okay.
Right.
If you have somebody that comes in and they got these balloon-sized ankles and feet, you may not get lower extremity sensory data. Okay. But if you don't, what needs to be done if you get no recordable sensory responses in the lowers?
You have to test an upper.
You got to test an upper.
Yep. Yep.
Okay, because normally a hand is not going to be as swelled up and balloon-like, like an ankle would be. You're going to go check, an upper.
Mm-hmm.
And even if this patient didn't have edema, and if we were really confident that these lower extremity sensory responses aren't there, what else are we still going to do? We're going to check an upper.
Mm-hmm. Absolutely.
And why are we checking an upper?
For polyneuropathy.
For polyneuropathy. Yeah. Practice parameter for a polyneuropathy is 2 extremities, and then at a minimum, a motor and a sensory in a third extremity. Okay. Somebody take a look at these, at these motor tests. And just because there's not a red box doesn't mean that there's not something abnormal here. Oh, we've got people raising their hands here. Jennifer, I didn't mute you, so I'm sorry.
Oh, no, I lost internet and now I'm
Okay.
back.
Okay.
No, both tibial motor nerves have decreased amplitudes significantly.
Where?
At the popliteal space.
Yeah.
Okay. So, yes, so there's a significant drop in amplitude. So what could be causing that? What's the most common cause of a drop in amplitude when we stimulate the tibial nerve up behind the knee?
Just not the right spot.
Well, yeah, we're either off the nerve or we're just not shocking hard enough. Or if this patient has, swelled up legs, we may not be, depolarizing the nerve.
Yeah.
There. Okay. Look at those peroneals. Anything wrong with those on the peroneals?
There's an amplitude different, or not an amplitude, a nerve conduction velocity of greater than 10 difference.
Yeah, but I'm not too worried about that. Yeah, but look at the segment length they're using. They're only using a 6 centimeter segment length, and at a minimum, I would want you using 8, something like that. So, but look at those. Look at the peroneal amplitudes. Somebody tell me what's happening with those amplitudes.
They are going down when you're going more proximal, which they should be at least maintaining themselves, or going up unless there's an entrapment.
So how much amplitude are we allowed to drop between segments?
20%.
20%. What's 20% of 6.3? 1.2.
2.
Yeah. What's 5.3 minus 1.2? Excuse me, 6.3
minus 1.2
is 5.1.
Right.
Okay, so what's
at
happening?
the most?
What's happening here? What do we call this on a phenomenon?
Conduction block.
That's called conduction block. Okay, and notice your system didn't give you a red box. Again, something that needs to be assessed at the time that you're doing this test. Okay, and entered into your data bank as you're testing this patient here. Okay, so we've got significant drop in amplitudes with stimulating the popliteal, stimulating the tibial nerve of the popliteal region, which is not unusual. Okay, in larger individuals or in individuals that have maybe some edema or maybe are guarding. But we certainly have some on a conduction block here. Okay, so we've got some motor abnormalities here. We've got some sensory abnormalities. Take a look at this H reflex here. We have an abnormal H reflex also. Bilaterally.
Which would indicate that's going up to the dorsal ganglion. So, because my question around the motors, well, that's a sensory to motor, right? But if you've got a conduction block at some point as you go more proximal, you're looking at the knee joint, but you would want to find something more proximal where it would be blocked. It would be blocked proximal to the point of compression. It's the area.
It certainly could be. What type of conditions would cause your H reflex latency to be prolonged?
Nerve root impingement.
Nerve root compression. On what else?
Some kind of polymyopathy or central
polyneuropathy. Correct.
Neuropathy, right?
On what else? Keeping in mind that you're assessing fibers from the tibial nerve at the knee, all the way proximal through the dorsal root ganglion, through the spinal cord, out the anterior horn cell, and then down to the medial gastroc.
So you could be an upper motor.
Well, upper motor neurons typically not going to give you a prolonged latency unless, Roy, there's an actual lesion within that spinal cord. Okay. So that's a possibility. It's just not common. Could a lesion? Yeah, peripheral
injury would still impact the H reflex.
Absolutely, plexus or maybe like a sciatic nerve injury. So so there's a lot of stuff that can cause you to have an abnormal H. Okay, so far, what we've got going on here, we've got absent sensories, We got prolonged H latencies, plus we have a significant side-to-side difference in latency, and we've got some on a conduction block, you know, on these motors here.
Right.
Did this impression address any of that?
No.
Okay, so this impression only talks about chronic axonal pathology, which would have to be a function of what test?
Well, VH reflex.
EMG.
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 Okay, so here's our EMG table. Okay, so somebody summarize what we're seeing here. Just to go ahead, start at the top and just, you know, work down.
Then you got to increase the insertional activity.
So we have increased insertional activity, and then they make a comment out here. And I'm going to assume that means they saw one CRD.
Right.
Okay. So increased insertional activity, is that more of a chronic component, or is that more of an acute?
Acute.
Acute. A CRD, is that more of a chronic or an acute finding?
Chronic.
So in one muscle, we have both acute and chronic findings, which could be possible. Okay. I mean, we could have an ongoing long duration process, you know, happening here. Okay. So let's go down to the other muscles that were abnormal.
So yeah,
Those two
reduced
get to be
recruitment.
on screen as longest.
Reduced recruitment of the posterior tibia.
So somebody explain to me what reduced recruitment means.
Means they can't fill the screen.
Nope, that is interference pattern.
Experience.
Oh.
And this patient had a complete interference pattern. Okay, so that's why we're questioning this. How can you have reduced recruitment but a complete interference pattern?
You can't.
Right.
Okay, so what are the two components that are abnormal that we usually see in a patient that has decreased or reduced recruitment?
Fast firing motor units.
Fast firing motor units is one. Okay, and Jennifer, why are they fast firing?
Because they're not recruiting a second motor unit.
Because there's not enough axons functioning to bring in more motor units. So if that's the case, how are you going to have a complete interference pattern?
It's impossible.
It's impossible. Okay. Also, I'm going to warn you about the peroneus longus and tib posterior. Okay, those are notoriously hard muscles to get to to the point of having a full interference pattern, especially the peroneus. Okay. Okay, so that's on the left side. On the right side, we saw the same thing. We saw reduced recruitment in the anterior tib and posterior tib. But we also had this 40%, greater than 40% polyphasics in the posterior tibialis, the most distal muscle that was checked. Okay, so question number one. Okay, we've talked about what's abnormal. We've talked about what's questionable. Okay, you cannot have a full interference pattern and true, reduced recruitment. Okay. Question three, do these EMG findings correlate with the EMG summary and the impression?
No.
No. No. Okay. Then second question, what other conditions could cause you to see these EMG findings other than a nerve root issue? And what do you think this patient might have? based on that NCS data, what other possibility for a condition might this patient have?
Are you talking
Oh,
specific
poly-
condition?
Just
Polyneuropathy.
Polyneuropathy.
Yeah.
yeah.
Polyneuropathy. This patient could have a polyneuropathy. In a polyneuropathy, will we see increase in social activity? Will we see CRDs? Will we see, and this is assuming that this EMG is correct. Okay. Again, with this gem, there were no buffers for me to look at. Okay. So I have to sort of believe that this is accurate. Okay. So could a polyneuropathy cause a patient to have polyphasic motor units, reduced numbers? Yes.
Yeah.
Yeah. What muscle wasn't checked, or what group of muscles wasn't checked that maybe could have pulled you more to this being a lumbar issue?
Paraspinal.
Testing the paraspinals.
Paraspinals. Yeah. This patient did not have any history of back surgery, I think. Yeah. We should have stuck some paraspinals. Okay. Can a polyneuropathy cause abnormality in paraspinals? Somebody say yes.
Yes.
Yeah. Yeah. I mean, absolutely. So looking at this body of evidence here, okay, the original impression, chronic axonal pathology, okay, what do we see typically in a chronic nerve root lesion? What type of abnormal findings?
Lower amplitudes.
Oh, what was that, Roy?
The lower amplitudes.
Amplitudes.
No, sir.
Polyphasicity.
We can see polyphasics, and what type of amplitudes will we see?
Long duration.
And what about size?
Large
Larger
long
than
duration.
normal. Larger than normal amplitude due to chronic, collateral axon sprouting.
Okay, yeah.
Okay,
That makes
larger.
sense.
So what in this data, if anything, points us to this being the only component of our impression? There is insufficient evidence to suggest a peripheral nerve entrapment. True or false?
False.
False.
False. Yeah.
There is insufficient evidence to suggest a polyneuropathy. True or false?
False.
False. Because we have evidence that there could be, assuming that this is correct. Okay. This is another one of these gems where I just want to, my hair just gets, I just want to sit there and, and pull individual eyelashes out. Okay. Because this person knows better.
Oh, wow.
This. Okay. So what would the correct impression be based upon this data here? Jennifer, this is somebody you see in your clinic all the time.
All the time.
So go ahead and spit out the impression.
This is an abnormal study. There's electrophysiologic evidence suggested of sensory-motor axonal and demyelinating polyneuropathy affecting bilateral lower extremities.
Okay. And then part 2 of that impression?
Superimposed polyneuropathic process, myopathic process, or lumbosacral process cannot be ruled out at this time.
Yeah. Superimposed focal nerve entrapment or lumbar nerve root
Lumbosacral
pathology.
plexus.
Yeah. Well, no, nerve root pathology cannot be ruled out.
Oh, yeah.
Okay. Because based upon this, to me, and I'm assuming that the data is correct here, this to me points way more towards a polyneuropathic process than chronic axonal pathology here. Okay. Anybody disagree? Anybody want to engage with me in stimulating conversation how all this data points to chronic axonal pathology affecting the L5 or S1 nerve roots?
No, I don't want to touch that.
Yeah.
No way.
Yeah. Now, that being said, what I can say is where we have this difference in latency side to side, 4 point, over 4 milliseconds different. Most polys are fairly symmetrical. Okay. So that latency is going to be fairly symmetrically prolonged. And this is why we add that statement that's, along the lines that superimposed processes, including lumbar nerve root pathology, cannot be ruled out, because we've got stuff like this, and we've got this, EMG stuff here too. But I don't know how much I trust any of this recruitment, because again, ask yourself the question: how can you have reduced recruitment and a normal interference pattern?
No.
Is that possible? At all?
No.
It isn't. Okay, so when you guys get to the point where you're board certified and you're starting to review reports, okay, if it doesn't smell right, it's probably a turd. Okay.
Yeah.
Okay. I mean, things sort of have to fit together. Okay. Is it possible that this patient just had edematous legs and we couldn't get sensories? Yeah, it's possible.
Absolutely.
But that's why we would go up and we would check an upper.
Mm-hmm.
Okay. And if that upper is blazing fast and normal, then we could revise our impression to say something along the lines, this was a technically difficult study due to edema, and just discuss it. But on what planet do we get to this impression?
Venus, Mars, not ours.
Yeah. Okay. I mean, could there be a little chronic axon? Yeah. But to say that there is no evidence of a peripheral nerve entrapment or a polyneuropathy is just plain wrong. Okay. Yeah. So if you guys were the mentor and you've just reviewed this report, what are you telling your mentee at this point? I mean, I'm going to turn this around on you guys here.
I'm bringing it back in, testing an upper.
Yeah. You're bringing them in, testing an upper, and what else, Kate? You're going to tell them to redo that EMG.
Yes.
Okay.
And include a paraspinal.
Include a paraspinal, and really take a careful look at that recruitment. I bet you that recruitment's normal. I bet you. I mean, if the interference pattern was full and you had a full screen full of motor units, there's no way that you have reduced recruitment. I mean, it's just.
Hey, Mark, I mean, can that just been that he didn't get the needle where he needed to get it?
Absolutely.
Yeah.
Absolutely. And that's why we got to have buffers to look at. Okay. If we're watching a whole screen full of this stuff and they sound muffled and distant, then right off the bat, the pin is not where it's supposed to be. It's not actually where those motor units are being generated. Okay, so let's take a look at another gem here. Okay. And it's sort of funny, Dr. McKibben, if he was doing this webinar from his office in his home, he'd probably have a nice glass of bourbon.
Yep.
With them. Okay, so looked at the and again, this is a machine generated report, and what it's saying is that for the nerve conductions, everything was normal, and for the EMG, it was saying everything's abnormal.
No way.
Okay, and then the impression. Check this out. Okay. There is electrophysiologic evidence suggestive of subacute axonal pathology affecting multiple cervical nerve root level bilaterally.
Interesting.
Whoa.
Okay. So let's take a look at some tabular data here. Somebody just take a quick look at this, identify anything that is abnormal or questionable here. Do you see anything here that is out of the ordinary?
Well, you've got your right ulnar at below is more than 20%.
Roy Adams, you get the cookie of the evening here.
Yeah.
So you got more than 20% difference here. And this is an easy calculation because 20% of 10 is 8, and this is less than 8. So the possibility exists there could be a little bit of, of some motor conduction block. On that left side, we're probably not there. It's close, but we're probably not there. Latencies all look good. Distances here all look reasonable. Actually, on second look, I would disagree here. So left median forearm segment 23, and then the forearm segment for the ulnar in the same limb 23. How's that possible? Because with the median nerve, we're stimulating proximal to the elbow. With the ulnar nerve in that blowable segment, we're distal. So how is that proximal? I just now saw that. So I missed that. Okay. But the nerve conductions are all normal. EMG here, or excuse me, the sensory nerve conductions all look reasonable. I mean, we've got reasonable amplitudes here. Radial, side to side. I mean, everything looks good there. So, not quite sure why we did a lumbrical to interosseous test, but you know what? Hey, that's okay. Okay, so really, the only thing here that's maybe a little bit questionable is this, is this little bit of some possible conduction block, with that right. Okay. And again, because there's not a red box, your machine generated report is not going to tell you that there's something wrong.
Right.
Okay. That's the limitation of using a machine generated report. Okay. And again, I'm going to get up on my pedestal, and say that, Dr. McKibbins and my mentees do not get to do, machine generated reports because you don't learn. We feel in years and years and years of doing this that it takes you twice as long to learn when you let the machine do this for you. Okay. EMG.
Oh, wow.
What?
Man.
Okay, so
They have buffers?
everything was abnormal here, right?
Yeah.
Allegedly.
They better have buffers.
Yes, there were buffers, and we'll talk about that in a second. Okay, so just seeing this on your EMG, what's the first condition that comes to your head when you see this type of EMG? Where every muscle is abnormal.
Would it be a myopathy?
It could be, but amplitudes here were normal. And what do we normally see in a myopathy? We normally see smaller than normal motor units in a myopathy.
Right.
Okay. What's the other big horrific condition that will present like this? Motor neuron disease.
Okay.
ALS.
Oh.
Okay. And unfortunately, I see 3 or 4 cases of that a year. People, walking to the clinic and they're having shoulder pain, because they've lost strength in their shoulder girdle, and the orthopedist sends them to you to rule out an axillary neuropathy. And before you know it, you're 4 extremities in on your EMG, and you're sticking the tongue in the upper trap, and that patient has, probably has ALS there.
Wow.
Okay, so if you see this impression, you're testing this patient, and every single muscle you've stuck is full of fibs and positive sharp waves, what else are you going to do?
Go thoracic.
Do the lowers.
You're going to do lowers.
Lowers.
Okay, and then somebody else said, what paraspinal muscle are you going to check?
Thoracic.
Thoracic.
Yeah.
And what other 2 muscles are you going to check?
So, tongue and upper trap.
Tongue and upper trap. Whose voice is that? Is that Roy?
Yeah, that's me.
Roy, you're taking over on this, webinar right now. Heck yeah.
Now, let me ask you one question, though.
Yes.
If those positive sharp waves are that far off, wouldn't the fibs be more involved in that too? Or would you
normally if I'm seeing 4 plus positive sharp waves, I'm seeing 1 or 2 plus fibrillations also.
Yeah.
Okay, so this certainly could be a presentation in a patient that has a C5, C6, C7, C8, and T1 nerve root in pathology.
Wow.
Okay. How often do we see that?
Never.
I mean, never. Okay. Again, this smells. This data smells. Okay. And if it smells, it's probably a turd. Okay. So, but that doesn't rule out the fact that if this is what you actually think you are seeing, that doesn't relieve you of the responsibility of completing the exam. Okay. So you're going to go at a minimum. You're going to check proximal and distal muscles in the lowers. You're going to stick the thoracic paraspinals. Why do we stick the thoracic paraspinals and not the cervical or the lumbar paraspinals? This patient did have a C5, C6 fusion, so that's why paraspinals were not checked. Okay, for this patient. But why do we go to the thoracic paraspinals?
To see if it's gotten all the way to the center of the body.
I like your reason, there, but that's wrong.
Oh.
How often do we see thoracic radiculopathy?
Never.
Like hardly ever.
Yeah.
Okay, I see 1 or 2 cases a year. How often do we see patients that have cervical and lumbar radiculopathy?
A lot.
I mean, quite often. So we want to go somewhere that's going to be relatively clean, and that is usually the mid thoracic paraspinals. Why are we checking the tongue and the upper trap?
Upper trap's goes cranial nerve.
And so is the tongue. Yeah. So we want to check a couple of cranial innervated muscles also. Okay. So seeing this type of presentation, certainly we would have not stopped here, but wait for it. Subsequent review of pertinent EMG buffers showed no spontaneous activity and less than 20% polyphasics. What was actually being observed were motor units. So all this crap, all this 4+ stuff was not positive sharp waves. They were motor units. Okay, so again, I'm pulling out eyelashes, here, and pulling out ear hairs, and things like that. Okay? So all this EMG goes out the window. EMG is clean. EMG is normal. Okay, so going back, okay, we've got some borderline on a conduction block here. Okay. But is there any evidence of subacute axonal pathology affecting multiple cervical nerve root levels bilaterally?
Nope.
Is
Can't
this a
do it.
correct impression?
No.
No. No, it's not. Okay. And that's why it's so important that we have confidence in what we're reporting. Okay. I'm hoping that nobody sitting at this webinar tonight is going to feel that this EMG table would be accurate, except for a more insidious process, like a motor neuron disease. Okay. So really, essentially, if we don't worry about this, little bit of, conduction block.
But don't you even worry somewhat that below elbow is slow?
Below elbow is slow.
I'm not slow. I'm not slow, but the amplitude is down there as being conduction.
Oh, Roy Adams, you are on the ball. Okay, so I'm going to put you on the spot here, Roy.
Okay.
What other phenomenon will present as having this drop in amplitude below elbow and above elbow segment? And the second part of that question is, how do you prove it?
Well, I may be striking out on both of these, Mark.
Anybody?
Cubital tunnel.
Well, yeah, but let's talk about a normal. What normal on a phenomenon seen in up to 18 to 20% of the population would present like this?
Yeah.
The key word is 18 to 20% of the population.
Yeah.
People are raising their hands.
Yeah. I know it is.
So Kay, I'm gonna promote Kay to a panelist, so she can answer this question.
What happened?
Okay, so what else could cause this?
Oh, don't be screen share.
On who said it?
Martin Gruber.
Martin Gruber.
Martin
Gruber. The brain, but yes. It's getting
Martin Gruber.
Sorry, I should have gotten that one. I was slightly distracted at the moment.
What were you distracted by? Nice
A
wood.
dog. Thanks. A dog who was trying to bark, and I'm trying to keep him from barking.
Was it Bandit or was it one of your other hounds?
It was the new rescue Della. She likes to bark.
Okay. Kay, by the way, I got to meet her, her dog Bandit, who is just wonderful. Just a joy to be around.
He's a registered therapy dog, so he goes to the office.
There you go. So if this is a Martin Gruber that's being picked up with the ulnar motor test, how do we prove it? What nerve would we stimulate and where to prove it?
Let's see. Median.
Median where?
At the fourth digit?
At the wrist?
No. No to both of those.
Okay.
You would record it.
It's still being recorded off the ADM.
Okay.
Okay. So where are we going to stimulate the median nerve?
Elbow.
At the elbow. Correct. At the elbow.
Because the anastomosis is distal to the elbow.
You are correct.
Correct. Yeah.
Who is your mentor?
The brilliant Dr. Brooks.
Okay.
You're stimulating above the elbow then for that?
You're stimulating in your standard median motor elbow on a position.
Gotcha.
Yeah. Okay, so again, this is questionable. So let's assume that this is maybe a Martin Gruber. Okay, because we have a blazing fast nerve conduction velocity across that elbow. Okay, so how do you write this impression now?
This is a normal study.
Yeah,
Yes.
this is a normal study. How's it possible to go from this and an impression of this, suggestive of subacute axonal pathology affecting multiple cervical nerve roots bilaterally? How does it go from that to being a normal study?
Operator error.
Operator error.
Technical error.
Yeah, lack of confidence, just, I mean, again, guys, if you see something like this, when you guys get into the boots of being a mentor and you see something like this, you're going to question it. Okay, I didn't. Gosh, I all I had to see was this impression. Subacute axonal pathology affecting multiple cervical nerve roots bilaterally.
Yeah.
Okay.
I'm really very, very.
Go ahead.
No, just, I mean, I would like, what's the clinical correlation that would ever show that?
Yeah. Yeah. I mean, I'm trying to remember the most number of nerve roots I've ever seen abnormal in one patient. And that becomes difficult because there's so much overlap. There is so much overlap between 5 and 6. There is so much overlap between 6 and 7. There's less, with 8 and T1. Okay. But, C8, T1 radix are extraordinarily rare there. So, I mean, again, this to me, if this was presented to me and I was told that the buffers were reviewed and they were accurate, to me, this would lead me down the pathway of a systemic condition like a motor neuron disease. Okay. And I'd be wanting to check additional proximal and distal muscles in that third limb, and then also check, some, cranial, innervated muscles along with the thoracic paraspinals here. Okay. So, I mean, again, these last two tests, you've heard me use the term gem. Okay. It's very unusual for me to see something like that, but the fact that two of these have come in basically 1 or 2 days apart is unconcerning. And the takeaway from tonight is, don't hesitate, okay, to not only question your data. I mean, if while you're doing that test, if something just doesn't make sense, okay, go back and take another look at it. Okay, go back and check your distance. Go back and take another run. Make sure that your cathode is pointed in the right direction. I see a lot of measurement error, type stuff there. If the pattern of the data that you're seeing just doesn't make sense, then we need to question it. Okay. And as a mentor, especially being on a remote, for most of the people that, I supervise, that can become difficult there. But, I am certainly, very, very happy to say that, that the vast majority of people that I review reports for, and that Dr. McKibben reviews reports for, and John, we're seeing significant progress, and that progress comes only as a result of time and getting more reps under your belt. I mean,
Right.
Jennifer, are you a lot more confident in your testing now than say 6 months ago?
Oh, heck yeah.
Yeah.
It only took a couple red marks from Brooks to.
Yeah. I mean, it only takes me opening up my, radial artery, onto her test.
In a constructive way.
In hopefully a very, very constructive way. And
No, absolutely. Getting the practice has been, pivotal, and actually
getting the reps,
spending time picking your brain about a lot of things is
getting
what's
reps is critical. I mean, it is critical. I mean, you've got to be able to establish a foundation and then continuously build upon that. And that's where, I'll say competence and confidence comes from. Okay. So again, as you're doing your tests, question what you're seeing. Because if you can pick up some of this sort of odd stuff at the time you do the test, that saves you a ton of hassle. That, and not to mention saves me, spares me, from having to say, yeah, you need to bring that patient back in. Okay. I mean, that really sort of sucks.
Yeah.
Gotcha.
I mean,
We don't like it either.
with being yes. Yeah. So when you have to bring a patient back in, how do you tell that patient that they need to come back in? What type of wording do you guys use to try to get them back into the clinic?
I usually say something like, upon review of my data, we found some things that didn't quite add up, so I need to retest just to verify.
Very good. Very good. And that patient normally says to you something along the lines of, when do you want me back? Type of thing, don't they?
Yes.
Yeah. Yeah. You don't have to say, yeah, I
screwed up.
I took too many Allegra that morning, and so all my data is hosed. So I got to bring you back and retest everything. I mean, usually when you say something along the lines, "Hey, we've reviewed the findings, and we're seeing some things that we'd like to take a better look at. Can we get you back in?" They'll be the first ones to say yes. Bring me back in. There. So, okay. So, whoops. Uh-oh. So, any other questions, either about this or about anything else that might be on your mind at this time that I could maybe answer for you?
Can I get a copy of your template? You mentioned being willing, the report writing template. You'd mentioned at the class that you're willing to share that.
Yes, I can send you. I will put a folder that has 8 or 10 different templates into your Dropbox.
Yeah, it'd be Optimum Health Report, CMG.
Yep, I can do that. Okay.
Sounds good.
Okay. So guys, as always, if you have any questions, even if I'm not officially your mentor, please feel free to shoot me an email or text me or call me or whatever. I'm here to help and to help guide you guys to that down that path to getting competent and confident in what you do there. So okay, guys. And
thank you, Dr. Brooks.
Thank you.
Thank you, Dr. Brooks.
Okay,
Thank you, Dr. Brooks.
Take care.
Bye.
Okay.
Bye-bye.
Bye.